So I've called this shrinking the gray zone, and you'll see why. That's a picture of Toronto at its best. Disclosures. So this is not a new concept of surveillance. We had what, in retrospect, was a pivotal publication 14 years ago, which was really the first time. Watchful waiting was an old idea, conservative management till metastatic disease. But it seemed to us there was a middle ground, follow patients, do the PSA, repeat the biopsy, treat the ones who look like they're progressing. And a lot has changed since then. This is just a summary of what is, I would say, different now compared to the original concept, which was now about 20 years ago. Certainly greater recognition of the overtreatment problem and acceptance of the concept of conservative management. No one really disputes the principle anymore. It was very controversial at the start, and we have the U.S. Preventive Service Task Force saying overtreatment, overdiagnosis is the key problem with screening, amongst others. We know much more about the nature of occult high-grade disease. So the Achilles heel is about 25 or 30% of Gleason 6 are misattributed. They actually harbor higher grade cancer. We know much more now about who those patients are, how to recognize them. The predictive value of baseline parameters. So based on tumor volume, PSA density, family history, race, and so on, you can actually identify patients who are at risk for harboring that higher grade cancer. The flaws of PSA kinetics. For the first 12 years, we used a PSA doubling time as a trigger for intervention. In our cohort, about 40% of the patients who were treated simply had a rapid rise in their PSA. We now know it's not reliable, it's sensitive but not specific enough. Too many cases of subclinical prostatitis, so it's now a trigger for evaluation but not for treatment. The game changer multiparametric MRI, we're going to hear a lot more about that at this meeting, but clearly imaging prostate cancer is a huge step forward, has many ramifications at every stage. New modeling studies that basically show conservative management is robust given the quality of life benefits, even if the mortality starts to creep up with longer follow-up. We have data on the benefits of 5-ARIs, and most strikingly, that's a PubMed search, active surveillance in prostate cancer. It's gone from almost nothing to now more than 2,000 publications looking at every aspect of this approach. So what do we know today? There's still a lot of controversies. I think the first key point is there is a general consensus that Gleason pattern 3 is a non-metastasizing cancer, and that the molecular genetics in most, but not all cases, looks normal. So the acceptance that finding pattern 3 is not associated with any risk of metastatic disease, unless the patient has something else that you don't know about, that of course is important, but that Gleason 3 doesn't metastasize is very powerful. And there may be the one case in 1,000 where it's a very well characterized prostate that only shows Gleason 6 that metastasize, but there's hardly any in the world that have been identified like that. And so I think it's fair to say that it's zero. On the other hand, true biologic grade progression is uncommon. The Gleason 3 that becomes a Gleason 4 or 5. It occurs, the estimate is around 1% of cases per year. It's mostly in a field of large volume Gleason pattern 3. But the misclassification of higher grade cancer is much more common. And of course, we've learned from the molecular biomarkers that you can have what looks like an innocent Gleason 3 that harbors molecular alterations that are much more significant. That does occur. That's the value of the molecular tests, which work in a complementary fashion. So this is a summary of a number of genetic pathways that are involved in prostate cancer pathogenesis, metastasis, invasion, whether it's angiogenesis, apoptosis, resisting growth inhibitory signals, and so on. It's remarkable how low power assessment described by Gleason 30 or 40 years ago separates these cells into those that are genetically normal in most cases versus those that are abnormal. There's some important exceptions. One is PTEN loss, which is considered a key molecular event in in the metastasis of prostate cancer, about 10% of Gleason 3 harbor PTEN loss. Just a little more about that, which is a study published recently that looked at this and found the PTEN loss in Gleason 3 occurred almost solely in those cases where there was coexistent Gleason 4. And so you can see here, this is the patients with pure pattern 3 with 3 plus 4 and 4 plus 5. The pure pattern 3, very rare to get PTEN loss. So there's something about the coexistent higher grade cancer that's influencing those. Now along the same lines, many of you are probably familiar with this remarkable case report, one case published in JCI, which was a patient who died of prostate cancer years after diagnosis and had deep sequencing of every metastatic site and of the various regions in the primary tumor. And to everyone's surprise, there was a clonal relationship between not the high-grade cancer, it was a 4 plus 3, but between the metastasis and that little red area, which was the one site of Gleason 3 that the patient had. So does this mean that Gleason 3 actually does have a metastatic potential? No. The best explanation for this is something that I think is not too well known yet, and that is its so-called extracellular vesicle transfer on cellular heterogeneity. So it turns out that cancer cells secrete these extracellular vesicles. One cell sheds thousands of these a day, and they contain biologic material, including RNA. And that RNA from the bad cancers can be taken up by the favorable cancer cells and corrupt them in a sense, or make them behave in a more aggressive way. So this has been shown clearly in animal models. There's a review article there published this year in Cancer Research that explains this in more detail, where basically aggressive cancers can make indolent cancers more aggressive in the same patient. And that's not only in the same tumor, in the same gland, but a metastasis to the primary and vice versa. So this has a lot of implications for example, treating the primary tumor in a patient with metastatic disease. But I think it's the perfect explanation for that otherwise very confusing case published by the Hopkins group. Just some of the evidence supporting this non-metastatic phenotype of Gleason 6, 12,000 cases from 5 centers of excellence, 20-year follow-up, basically no true Gleason 6 that had metastasized, and the same thing, a lymph node paper, 22 of 14,000 had positive nodes that were Gleason 6. They were all upgraded on re-review. So that's where the kind of publications that support this statement that essentially it's a non-metastasizing cancer. So if you accept that, then why should the volume of Gleason 6 matter? Because every guideline, NCCN, NICE, Canadian guidelines, makes the distinction between low risk and very low risk. And usually very low risk just is 1 or 2 cores positive, no extensive core involvement, etc. It does make a difference, and it's because the volume of the Gleason 6 we now know is a predictor for the coexistent higher grade cancer. So you don't have to treat that patient, but you have to watch them, scrutinize them more carefully. This is the wolf in sheep's clothing with the high grade Gleason 8 sitting in the anterior prostate that you don't know anything about. The likelihood that that's there is higher with higher volume disease, and the evidence for that comes from, this is a meta-analysis of this topic, predicting disease reclassification, which basically means Gleason 7 or higher, and the major predictors are PSA density, which is a surrogate for higher volume, race, blacks have a higher risk for a variety of reasons, and extent of core involvement. So around the world, there's now about 10 groups that have reported prospectively, and they have a variety of selection criteria, and this represents somewhat of a natural experiment. And the two ends of the spectrum are the Sunnybrook group, which is ours, and the Hopkins group, which is led by Bal Carter. We took an inclusive approach, so we included 3 plus 4. We included patients with PSA between 10 and 20. We even had a few 4+3, and the idea was to really try and evaluate the limits of surveillance, and these were also patients who were very motivated to avoid radical therapy. The Hopkins group, probably for a variety of reasons, philosophical differences, maybe fear of lawsuits, who knows, they took a very conservative approach, only patients with 2 or fewer positive cores, Epstein criteria basically. And they treated patients who had volume progression more than Epstein criteria. So if you had 3 cores on a rebiopsy of Gleason 6, you got treated. So we have 22% intermediate risk in the cohort, about a third of these under age 70. And we have a number of patients who've gone on to develop metastatic disease, 30 out of about 1,000, 3%, and 1% have died of prostate cancer. So this is our data. Noel just showed some of this, about 40% got treated. This already is part of the problem, because we now know today this curve should look like the red line. We should find those 25% with the adverse cancers right away. And the value of MRI and biomarker is going to be to change the black line to the red line. On that note, though, this is a recent study that compared the indications for surveillance, the eligibility, according to the likelihood of treatment. It's remarkably similar. Even with broader indications or inclusion, you still have roughly the same rate of treatment. And we have 5% prostate cancer actuarial mortality at 15 years. In fact, only 1.5% have died, but if you extrapolate out to 15 years, it's 5%. So I used to think that was pretty good. And this is the metastasis rate. So you can see about half the patients probably had a high-grade cancer that had already metastasized at diagnosis. And there were clearly a group of patients, about 1 to 2%, who metastasized late and perhaps were curable if we treated them earlier. And this turned out basically to all be the Gleason 7. So this data just shows the likelihood of metastasis as a function of risk, low versus intermediate, almost 0 for the low risk, and 11%, 4 times higher for the intermediate risk. It really made a difference, and it was all the Gleason score, not the PSA. So the Gleason 7s here, 77% metastasis-free survival at 15 years, and that explained almost all of the metastasis in our group. And if you break this down by subgroup, called recursive partitioning analysis, there's the sobering observation that even in the very best, these are the Gleason 6s over here, all of them have like 95 to 98% metastasis-free survival at 15 years. No Gleason 7 patient had better than 80% metastasis-free survival. Even the most favorable group is down here, and only 70% in the low volume, PSA less than 10, et cetera. So we've become more conservative. And here's the Hopkins data that Noel just showed. They were restrictive, and the payoff was 0.5% prostate cancer mortality. So you restrict eligibility, you do better, but it means you can only offer surveillance to about 20% instead of about 50%. It's a classic medical trade-off of risks and benefits, and clearly there's a middle ground, which is probably the vast majority of men with Gleason 6 and very restrictive patients with Gleason 7 who are candidates for surveillance. And this shows you the overall mortality and the prostate cancer mortality around the world. The Gothenburg group took a similar approach to ours. Marsden group, as I understand it, was similar to Hopkins. UCSF, I don't think, has long enough follow-up to start to see those. Now, PROTECT. Everyone, I'm sure, has seen the data on PROTECT. You can derive whatever conclusion you want to from this study, in my opinion. No difference between surgery, radiation, and active monitoring in terms of prostate cancer survival, but a difference in metastasis rate favoring the radical treatment group. What are the implications of this for surveillance? In my opinion, what it shows is very low mortality rate And if you include Gleason 7, a quarter of the PROTECT patients were Gleason 7 or higher, you do start to see some metastasis. So this should not be interpreted as active monitoring not being good for patients with Gleason 6 disease at all. And then finally, we're in the MRI era, and just to show the key metric is the negative predictive value for men on surveillance. You want to be sure they don't have something worse. A negative MRI is associated with up to 100% negative predictive value. The Panabianco study is not listed here, but you can see 98, 96. There's a few outliers that show that it doesn't work as well. And why the negative predictive value is lower in some studies is something that's still being worked on. But you can imagine a patient with Gleason 6 in one core on a systematic biopsy. Now all of a sudden we have his MRI that shows this, a PIRADS5 lesion, and we target that for biopsy and treat it when it shows higher grade cancer. We are no longer going to have that 5% 15-year mortality. This is going to really transform the ability of surveillance to get closer to 100%. So I think the new very low risk is Gleason 6 with a negative MRI, and just to show some of the studies that support that. Biomarkers, we heard about a little bit, the 4 biomarkers that are now on the market that claim to say this patient is at higher risk or lower risk for progression. One of the issues with the biomarker story is they all use most of them use the endpoint, the likelihood of higher grade cancer, but it's not clear, is that coexistent cancer that was missed, or is that really a Gleason 6 that is destined to progress to a higher grade cancer without treatment? And we're just starting to see data on the marginal utility of the biomarkers in the MRI era. We haven't had it before now. And this is just one study published recently that I thought was a bit of a caveat about the biomarkers. And this was a whole genome sequencing. This shows 4 different patients, and each one of these bars is a different area of the prostate. And with the whole genome sequencing, they were able to derive the Oncotype score, the Prolaris score, the Decipher score. And what is striking is for each one of these prostates, there is a lot of heterogeneity between different tumor sites in each gland. Now, mostly going in the same direction, although not entirely. But you know, this to me is a real problem with the biomarkers. If you have such heterogeneity between sites in the same prostate, how reliable is that going to be to tell you that the patient is at high risk or not? So I think, let me just move through this one in the interest of time, just to say that the trend for surveillance around the world is remarkable. So this is 6 different publications from all over the world. This is New Hampshire, this is Capture from Cooperberg, this is Michigan, this is Australia. The blue line generally is the surveillance, the yellow line here, up, up. This is Canada. We're quite proud about this. These are 6 different regions in Canada, and it's somewhere between 80 to virtually 100% of eligible patients managed with surveillance. And here is Sweden, just reported recently that more than 90% of eligible, very low-risk patients in Sweden managed with surveillance. So the world is changing. There's also the opportunity to intervene. This publication about active holistic surveillance from Aaron Katz and others, and you want to give the patient dietary advice and put them on a bunch of supplements, you can do that. None of these have really been shown to make a difference, but they all have preclinical data that looks promising. So I started by saying this was about shrinking the gray zone. Here's the traditional gray zone, huge in prostate cancer. Prior to, say, a decade ago, even less, even 5 years ago, this was the black zone, T1A. No one was treating post-TERP microfocal Gleason 6 with radical treatment. It was considered wrong. And I think we're moving to an era where the black zone is much larger. Patient with Gleason 6, small volume disease, MRI normal, low PSA density. It's black and white. Those patients should not be treated. There's still a gray zone, which is the large volume Gleason 6, the very young men who have Gleason 6, under age 50, say, the ones who have a small amount of Gleason 4. The ones who have an MRI that looks like it's very ominous, biopsy doesn't show anything, and the ones with a high PSA density. And of course, there's the patients with high-grade cancer still warrant treatment. But I think over time, this small zone is going to shrink further with better understanding. In the long run, we use Noel Clarke's molecular assays, and it'll tell us clearly this patient is destined to progress, this one is not, no more gray zone. So I think I'll stop there. Thank you very much. Happy to take some questions.